Welcome to AETCM, the Emergency Medicine Channel. Ma'am, today we are going to discuss a case of a 19-year-old male who came to the ER with complaints of breathlessness. Initial 19-year-old male was rolled into ER with complaints of breathlessness since today morning. On initial primary survey, airway was patent. He was able to talk in one full sentence and there are no secretions in the airway. Next, coming to the breathing, saturation was 97% at room air and respiratory rate was 40 per minute. In view of the increased tachypnea, oxygen mask with 4 liters of oxygen was...
He was having normal saturation, no?
Yes.
Normal saturation,
Tachypnic.
How was the air entry?
Air entry bilaterally equal and no added sounds.
Okay.
Then coming to the circulation.
So why did you start oxygen to this patient?
For the tachypnic part,
What are the causes of tachypnea with normal saturation?
panic
Panic attack.
and metabolic acidosis compensating.
Metabolic acidosis, especially young male and all, decay can be there.
Yeah. Then
Why metabolic acidosis patient is having increased respiratory rate?
to compensate the metabolic acidosis, he has to have respiratory alkalosis. So for that, he has to hyperventilate.
Not for respiratory alkalosis. In order to wash out the carbon dioxide and maintain the pH, patient will be that is acidotic breathing. Okay,
Then
any infection initial stages, it will have patient will try to compensate for the desaturation.
the patient is having fever. There can be tachycardia and tachypnea can be there. Then in case of if the patient sensorium is not there, in case of any IC bleed and all, patient can have tachypnea. In this patient we are not suspecting, and this patient is a young patient, so patient can have any overdose, any drug overdose or any illicit drug use and all. In such cases also there can be tachypnea.
After
So this patient ideally at present before evaluation we need not start oxygen. We need to check for the air entry. In the breathing itself we need to check for the air entry, look whether it is equal or not, or if at all not equal, then we will have to think in terms of
what? If it's not equal, then we have to think if it's any
pneumothorax, hemothorax or anything. Okay.
Next, coming to the circulation part, ma'am. Pulse is 80 per minute and BP is 130/70. When peripheral pulses are palpable, ma'am. Next, coming for the disability, patient was having full GCS, E4, V5, M6 and bilateral pupil reactive to light. And next, coming to the exposure part, patient's GRBS was 86 and temperature is 95.7.
So no fever, no hyperglycemia.
But only tachypnea. Patient is only tachypnic. So coming to the known case, his known case of CKD stage 5 and his twice.
So this patient is this much tachypnic. What adjuncts did you do?
This patient we got the ABG done, ma'am. In ABG the pH of the patient was 6.9 and bicarb is 8.1. Saying severe metabolic acidosis.
PCO2?
PCO2 is 35.
PO2?
VBG was taken, not the ABG. We can get the ABG.
So this patient is having metabolic acidosis. What was the anion gap? 17. Okay. So what can be the causes of this one?
Severe metabolic with high anion gap, which can be uremia, like methanol poisoning, uremia, DKA, paracyclate poisoning, and isoniazid.
Paracyclate.
Paraldehyde or salicylates. Salicylate and isoniazid also causes.
Okay. Then, so what all things can be so we have a high anion gap metabolic acidosis patient with you. Then what else is there in ABG?
In other electrolytes wise, potassium was 8.6, ma'am. Sodium 130. So hyperkalemia was there. Metabolic acidosis with hyperkalemia. And lactate was 14.
Lactate was 14. Okay. Then creatine?
Creatine 13.
13. Glucose?
Glucose 86.
86. So this patient, what can be the cause of this high anion gap metabolic acidosis? This patient.
Lactic acid.
Lactate is elevated, then?
And create, he's a known case of CKD with the
So lactic acidosis is also lactic acidosis along with the uremic acidosis is there. Okay, this patient's potassium is very high. So how will potassium correlate with the metabolic acidosis?
Usually acidosis, hyperkalemia.
Usually metabolic acidosis is associated with hyperkalemia. So like how
Mechanism.
in what increase with potassium does the pH vary? If the potassium, if the pH is dropping by 0.1, potassium will drop, potassium will increase by 0.6. Or if potassium is increasing by 0.6, pH can drop by 0.1. Okay.
Here potassium was 8.6, ma'am. And so this patient ECG was, we started with the anti-hyperkalemic measures.
Before to decide on anti-hyperkalemic measures, you need to take an ECG. Why?
To check if the heart changes in the hyperkalemia has induced any changes in on the heart electrical activity.
Okay. So what all will you expect?
First initial changes would be tall T waves, then absent P and widening of the QRS.
Tall T along with shortening of
the PR interval. And then absent P waves and widening of the QRS. After that, it can be broad QRS with sine pattern.
Sine wave pattern, bradycardia can be there. Then patient can go into arrhythmias. Okay. What does the change in this?
In this, the patient had a broad complex QRS.
Broad
QRS complex.
Okay. So ECG variations are there. Okay.
Yes.
So adjuncts to primary survey, this much things you should do. You should take an ABG. You found that patient is having severe metabolic acidosis along with hyperkalemia. You took an ECG. You saw that this patient is having hyperkalemic ECG changes. And what did you do now?
The initial management would be consisting of protecting the myocardium from the hyperkalemic changes, which includes giving injection calcium gluconate 10 ml of 10% over 10 minutes, connected to the defib to see if the patient doesn't go into bradycardia. And the other important changes would be transcellular.
Why we are connecting to cardiac monitor?
To see that the calcium, which there will be no rapid bolus of the calcium, because rapid bolus of calcium would cause.
Other thing we have to see is we need to see the response to that. When can you expect the response to calcium gluconate?
20 to 30 minutes.
Response will last up to 20 to 30 minutes.
The response will be immediate.
Initiated within 10 minutes.
10 minutes.
Okay. Then what else will you do?
Then we will be trying, the second line of hyperkalemia management would be targeting transcellular shift of the potassium from the intravascular to the intracellular component. Here we can use the help of the insulin and the beta agonists. Insulin can be given as the glucose is low. We can give insulin along with the D2500 ml with 8 units insulin together like a GI bolus. And the other would...
GA bolus is not a fixed dose. We can give whatever. If the patient's sugar is high, we can increase the insulin. And only thing is that we'll have to give it IV.
And the other is the beta agonists, which we can use here as the salbutamol. We can use the nebulization with salbutamol.
How much will you take?
We take 2 mg in hand.
You can take 5 to 10 mg. Then how will you give nebulization? Nebulization we will have to give along with 4 ml NS. We will have to add and then we will have to give nebulization.
5 mg and 4 ml NS and nebulize. We continue cycles of 3 cycles as such.
So you have talked about the cardiac protection for cardiac pressure and ECG variation. You have given calcium gluconate for shifting the potassium into the intracellular space. We are giving GA bolus and nebulization with astatine.
Then other component would be removing the potassium from the body. In that we have to we can target with Lasix. We can give diuretics through the kidney. We can or to the GIT by giving resins. SPS.
So diuretics you can give furosemide. Resins what will you give?
Sodium polyethylene sulfate. SP.
Sodium polystyrene sulfate. Okay,
Polystyrene
okay. This can be given. Okay.
But that would be, resins would be a long acting. It cannot immediately reduce. It will take 24 hours for its action to start.
Okay. So this patient, we know this patient is having
Acute
hyperkalemia because of
emergency.
renal failure. Maybe
Yes.
because of renal failure. What are the other causes of hyperkalemia? In general.
In general, hyperkalemia, first thing, it can be a pseudo hyperkalemia. We need to rule out. It can be when the muscle contracted, like, or the sample has been withdrawn and placed for some time. After ruling out these causes, then we have
Why is if samples placed for some time, it will the potassium-
lysis of the cells, RBCs and WBCs will cause the intracellular potassium to come into the intravascular component. And
Similarly, if the patient is having leukocytosis also, this patient's potassium will be elevated. Then
transcellular shifts, like in acidosis, usually potassium will be high, and along with that, if the patient is on this angiotensin receptor blockers, there can be high potassium.
that is not shift hyperkalemia. Transcellular shift can cause in case of using beta antagonist.
Then any angiotensin blocker.
It can cause hyperkalemia. Then what are the other drugs which can cause? So beta blocker, ACE inhibitors, ARBs. Then digoxin. Then
And ma'am, like this
in CLD patients, what drug will you give? Not terlipressin.
CLD patients we give.
COPD patients, if you are using terbutaline, that can cause. One drug which we are giving to prevent hypokalemia, that will cause hyperkalemia. What is that?
CLD.
Hypokalemia to prevent KCL syrup.
Not syrup KCL. Syrup KCL, okay. Then along one tablet which will cause
Perino.
something sparing diuretic. Spironolactone. Okay. Then any body destructions like rhabdomyolysis, then any tissue injury, this thing can cause. Okay. Continue.
So
Then the rest of the things are some syndromes. Type 4 renal tubular acidosis, and then rest of the syndromes. Okay.
So to permanently remove the potassium, we can try with the dialysis or the resins, and
But it's not working if the anti-hyperkalemic measures are not working, and if this patient is having refractory hyperkalemia, then we will plan on giving dialysis. Okay.
Ma'am, and the other thing would be even trying with sodium bicarbonate. If there is severe metabolic acidosis with hyperkalemia, we can give soda bicarb.
What is the problem in giving sodium
If
bicarbonate?
soda bicarb is given, metabolic acidosis would come into metabolic alkalosis, causing respiratory depression. Then
That side effect is there. So if you are giving sodium bicarbonate, we need to give very slowly. Only in case of cardiac arrest, we are supposed to give
soda bicarb. Or if a patient is intubated, we can
intubated patient we can give. What are the other indications of soda bicarb?
Other indications of soda bicarb would be
Other than hyperkalemic cardiac arrest?
correct potassium.
Any toxicological indications, Jared? For urinary alkalization, what will you give?
Soda.
For which all toxins will you plan on giving urinary alkalization? Like TCA poisoning, salicylic acid poisoning. These all conditions we need. These are acids like tricyclic antidepressants, salicylic. These are acids. For the removal of these things, we need extra bicarbonate. So for urinary alkalization, we can give soda bicarbonate. That can be given as a bolus dose, 1 to 2 mg per kg bolus dose, followed by infusion. Okay.
Next, for this patient, then further history as a secondary history, we get to know that the patient is a known case of CKD and twice weekly dialysis, ma'am. And the events leading to this is in the last 2 days he had taken bananas, which is a high source of potassium. As the kidney is already in failure, it could not excrete, so he was into hyperkalemia.
Was he anuric?
Yeah, he is anuric patient. So the treatment was initially by giving the anti-hyperkalemic measures with calcium gluconate. The patient's ECG pattern has changed from broad QRS into normal sinus rhythm. It has changed. Apart from that, giving after giving the anti-hyperkalemic measures, we called for the dialysis, and patient was dialyzed for 4 hours, after which the potassium has come down to 6. And
Why was the lactate so high?
ma'am, for that lactate was high because at that time it was...
Either it can be because patient is having associated some sepsis, something which is causing hypertension and elevated lactate, or it can be because of the effort he was tachypnea, because of the effort patient's lactate might be. Anyway, it is not looking like a type A lactic acidosis because his oxygenation was okay. So it can be because of the excessive muscle activity or sepsis. Okay.
After the dialysis, patient's vitals were normal, and repeat VBG was saying acid-base disorder. With lactate also came back to 1.5 mm, and potassium was 6. So post dialysis, the
Patient improved.
Patient got improved, and for observation was admitted under nephrology for 1 day and then discharged.
Okay. Which all are the dialysable drugs?
Antibiotic.
Dialysable drugs means if at all the patient come with some overdose and all, in which all conditions, if you give dialysis, you will be able to clear it out.
Paracetamol.
Paracetamol cannot be cleared. If this patient is taking one medication, that patient can have elevated lactate, and if this patient is having renal failure, that can cause a renal failure with worsening of RFT, and because of that, clearance will be affected. Which is the drug?
Organ.
One drug which can cause lactic acidosis. Metformin. So if this patient is on metformin, and if you are dialysing this patient, lactate will come down. Lactic acidosis because of metformin. That lactate will come down, and because of dialysis, rest of the acidosis also will improve. Then other than this one, leave the lactic acidosis apart. Other than that, which all are the dialysable drugs?
Antihypertensive.
No, like drugs as such.
Okay.
Some toxin, something which can be dialysed out.
Which can be dialyzed.
You remember it as Blissmed. Like B for barbiturates, L for lithium, I for isoniazid, T for theophylline. Okay. Then methanol, ethanol, and dabigatran. So which are they?
B for barbiturates, L for lithium, I for isoniazid, then this S for salicylic, S for salicylic, M for methanol, E for ethanol,
T for theophylline,
T for theophylline, and D for dabigatran.
Methanol, ethanol, and dabigatran. Okay.
That is dialysis.
Then what happened to this patient then?
He was discharged post observation. He was normal for 1-2 days.
So was he on maintenance dialysis, routine dialysis?
Twice weekly.
Dialysis. Which all are the other indications for emergency dialysis?
Emergency dialysis, if this refractory hyperkalemia, and then patient having refractory hypertension.
Hypertension.
No, sorry. Refractory anuria for more than 6 hours. And bicarb less than 7.
Anuria for more than 6 hours, that we need a separate criteria. Oliguria, anuria, depending on this thing. Then
bicarb less than 7. Severe acidosis.
Severe metabolic acidosis. Then
metabolic acidosis, electrolyte abnormal hyperkalemia changes, Then ionic changes toxins, uremia, and
Uremia. Which all uremia?
volume overload.
Volume overload, nephrogenic pulmonary edema. Then which all uremias? What are the uremic manifestations?
Uremic gastritis, uremic encephalopathy.
Uremic gastritis, usually it is not an indication for dialysis. Only if the patient is having excessive urea which need to be dialyzed out, only we will be doing. But other than that, uremic encephalopathy, then uremic pericarditis. Then also we will be planning on a dialysis. Okay. Thank you.